relationship between you and the patient, but we are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
The team was so human and kind. They helped me psychologically every day. I was waiting for the call every day with impatient. So that period was really very hard for my family. The team of ICU became really my family. I felt them closer even than my parents. Every day someone from the team called me and informed me about the situation of my husband and the next steps to do. And I want to say that even if I was far from my husband, I have been always updated about his clinical situation. And when there were very important decisions to make, for example, like tracheotomy, they called me 5 times per day. So I want to say thank you. For me, it was a new experience, like for many other people. I have never faced ICU. So after this experience, I changed my life. I changed all points of view. It was a really very hard period, and I was about to lose my husband, but I have never lost hope, and I tried to be strong, rational. I remember my first visit in ICU very well, because it's impossible to forget. It was so emotional. After 64 days, finally, I could see my husband, touch his hands, see his eyes. It was really very difficult to live without him and without personal contact. I don't have enough words to say thank you to the doctors for that possibility that they permitted me to visit him in ICU. Thank you very much. I'd like to say to the future patients and their families that they should trust to the staff of ICU. They're allowed in the hands of professionals that work tirelessly with passion and love. They are always with the patients. The patients are the primary focus for them. They always gave the warm care and necessary treatment. They never leave alone patients. They are always with them and ready to help them in any moment. The patients are the primary focus for the staff. In the end, I want to say, no matter how ill is the patient, don't give up hope.
Having a loved one in the ICU can be an extremely distressing experience. Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disorientated. So don't forget to take care of yourself. Sometimes you will need to take a break. You don't have to stay with the patient 24 hours a day, and you mustn't feel guilty if you do need to take that break. Don't forget that the ICU team will continue to care for the patient while you're not there, and they will always call you if there is a change in his or her condition.
My name is Sylvia. I'm a critical care nurse. I work in an intensive care unit. My work is to assist the doctor and to help them to prepare the patient to get all the medicines and the treatments they need in the ICU. When the family first enters an intensive care unit, I will receive them and welcome them and present them the room and the patient and explain the condition of the relative. I will be there to receive also their emotions, how they are feeling about it, and explain them what the patient is feeling at the moment, what we are going to give them for treatment. We will be there in any case to help them to go through these days in the intensive care unit and to perceive and communicate with the patient. We will be there to help him and assist him to the toilet, to the feeding, and to do anything that the patient will not be able to do. But moreover, we also will be there to see how is he feeling, if it's uncomfortable, if it's in pain, to learn to communicate with him all over the stay with all the equipment he will have. We will explain them the things that will happen to him and to his family, and to interact between the doctors and the patient.
The main role of a physiotherapist is the rehabilitation of the patient. With the term rehabilitation, we mean restore the previous situation that the patient had before his or her injury, his or her trauma. And so the patient could have again his or her previously autonomy in the best way it could be possible. A physiotherapist could work inside the intensive care unit, so it is a member of ICU team for all his or her working time, while in other countries the physiotherapist comes to ICU just only for the rehabilitation moment.
Hello, my name is Stefan Schaller. I'm an anesthesiologist and intensivist. As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients. My role is to coordinate the healthcare team to do the diagnosis and the treatment of the patient. To you, as a family members, I have to explain what is going on with your family member in the ICU. I explain to you what we are doing for diagnosis. I tell you the options for treatment and how to treat the patient. Very often we have to discuss what are the wishes of your relatives, although he's not responsive. Therefore, we discuss together with you what is the best care we could provide for your relative. In the beginning of your ICU treatment, very commonly you are unresponsive. You will be examined by me or a colleague every day. We will make the diagnosis plan and the treatment plan. Later on, when you're waking up again, we are starting to talk with you about the treatment plan as well. While you are unresponsive, we try to discuss the care with your family, or we look at any documentation you provided, how the care should be provided for you.
As a social worker, I'm part of the ICU team. I regularly come on a daily basis to the ICU and talk with the professionals on issues with the families or with the patient. For example, when it's about communication or when there are conflicts, but also when the families have a request so that I can help them to overcome that issue. What I notice is that the families have a really difficult time. They are stressed about their loved one, but they also have, for example, issues for themselves. For example, they have questions, can I take my children into the ICU? Or how can I manage the homework? Or what can I do about financial problems? So I try to help them with that kind of issues. And sometimes they are also asking life questions, because, for example, why is this happening to me or to us? And what's the meaning of this, that he or she is going to have this critical illness? So I try to help them with this kind of issues. My relationship with the patient is to get him or her to learn him better. And I think it's very important to have the values, what is important for the patient, to have them bring into the care that we provide in the ICU. And I think that it is compassionate care, humanizing care, and that is combined with the highest technical and medical treatment that we provide. And in that way, we have excellent care that we can provide in the ICU. And I try to bring my expertise and to have the patient and his meanings and his opinions in front of it.
A special aspect in my daily practice is the communication with the patient and the communication with the families. Communication in ICU is very difficult because clinical situation is very complex and sometimes it's not so easy to explain to families. And in my opinion, the most important thing is to try to keep it very simple, not to spend a lot of technical words, but I just only try to explain the clinical status with simple words. It's very important to try to develop a relationship with the patient and try to keep it quiet to tell him that the situation is under control. It's very important to maintain a patient calm and confident with the team, because very often the patients are very scared by the environment of the ICU. So it's very, very important to guarantee the comfort of the patient.
We work together as a single team with patients and families, and that's crucial for the recovery of our ICU patients.
Good morning, good afternoon, good evening, wherever you are in the world. On behalf of the ESICM, I'd like to welcome you to another exciting webinar. This week, we will focus on the patients on the wards who are at high risk of deteriorating. And we have two expert speakers who will address some important aspects relevant to patient care and the clinical practice of intensivists in the intensive care unit. I'm grateful to the ESICM for organizing this webinar, and I'm grateful to GE Healthcare for supporting it. We will have two talks, one by Dr. Bryden, one by Dr. Azule, and then have time for questions at the end. So I would like to invite the audience to put potential questions into the chat box, and I will ask them at the end of the talks. Without further delay, I'd like to invite the first speaker, who is Danny Bryden, well known to clinicians in the UK. She's the Vice Dean of the Faculty of Intensive Care Medicine and a practicing intensivist in Sheffield. And she will talk about how and why enhanced care and monitoring can improve effectiveness and productivity in the operating room and also in the intensive care unit. Danny, the floor is yours. And please put questions in the chat box and I will ask them at the end.
Thank you, Marlies, and thank you to the organisers for inviting me to talk to you. So first off, I would just like to show you my declarations. I am the Vice Dean of the Faculty of Intensive Care Medicine, and it is the community of intensive care clinicians in the United Kingdom that initially identified a need to develop enhanced care services. So it's a service development that has come from the intensive care community in about 2015, and during the pandemic, we have been working with other organisations in the UK, the Centre for Perioperative Care, to look at how we could develop this concept as a developing service for the future. So my talk this afternoon will focus very much on the surgical group of patients. And what I would like to do is describe for you the rationale for developing surgical enhanced care services and how a service like this would fit into perioperative pathways. I want to outline some of the possible models for enhanced care and hopefully show why this project is perhaps not as easily defined as perhaps other intensive care services, but it has some potential benefits for the future in the fact that it isn't quite so strictly defined. So I think we all know that there has been a significant variation in terms of the pressure that we have had on our intensive care units over the past 2 years as regards the pandemic. And also we've known that we've had quite a significant variation in terms of the provision of critical care beds. And certainly in the UK, it was very much held to be a case that we were underprovided for critical care beds. and it is something that we need to address going forward. But I would consider that wherever you are within Europe at the moment, there are pressures on your services, and it is not a situation that having more intensive care beds necessarily means that your services are not pressured. If you add to that the fact that certainly in many countries, the way that they have coped with the increased demand on their hospital services and critical care beds is to cut back on some of their elective operating services, you have a situation where a delay is built into the demand for elective surgery going forward. And the graph on the left is a graph of the UK services from a well-respected institute, the Institute for Fiscal Studies. And it basically shows that we had about 4 million patients in the UK waiting for some kind of operation at the start of the pandemic. Now, not all of those by any means will obviously require some critical care support, but we had about 4 million people. And then the graph's subsequent projections in dotted lines show the variation of numbers of people that we may have waiting for surgical services in the future. And to a certain extent, we have no idea of knowing how many people are out there who will be requiring some kind of support from a critical care service as we go forward in the next few years. The worst case scenario for us at the moment in the UK is about 15 million people who will be requiring some kind of surgical procedure by the summer of 2025. If you add into the fact that those of us that have been subject to numerous lockdowns or long lockdowns and the impact that the lockdowns have had on population health and psychology, we are already starting to see a significant number of patients who are increasingly deconditioned, not just in relation to the delay in the presentation for their condition, but also in relation to obesity and lack of exercise. So we have a situation of an increasing number of patients who are waiting for surgery, a number of them who are presenting later, and on top of that, those that are presenting are often perhaps not as fit as they might have been earlier on in the pandemic. And this is obviously a significant concern. Now, initially, the focus in the UK has been very much around we must do more. So looking at ways of turning on our productivity, particularly in relation to elective surgical services and operating on more cases and getting more patients through. But I think one of the concerns around that as an approach is the fact that we know our healthcare systems have not been completely robust, and that just doing more in the current situation will expose some of those cracks and those problems in the system that we knew were there. So many politicians may feel that doing more is a sensible option, but I think many of us as clinicians know that there are some system changes that we need to make if we are going to be more productive. And really, this is where the concept of enhanced care comes in. So as I said, although it came from the critical care community in 2015 and it was before the pandemic, I think it very much is a service development that could help us go forward as we live with COVID and as we move to a different way of working in the future. There is a gap. We knew there was a gap between the care that is provided for a patient on an intensive care unit or a critical care unit and the gap that is provided in terms of a ward level care. And certainly in relation to COVID, in relation to the UK, that gap has been growing, not narrowing. So this is where an enhanced care service is envisaged to provide support for that gap and the patient that may fall through that gap. And again, in the UK, we have been engaged in some sort of analysis that started before the pandemic, but that has continued through the pandemic, looking at how we can improve our services for patients and get it right first time. So the Getting It Right First Time programme has focused on a number of surgical specialties and in addition critical care and anaesthesia and perioperative services. And one of the things that it has illustrated is the fact that we have an inconsistent provision of critical care support to patients around the UK. The factors that seem to be common themes throughout that are really down to sort of three main headings. Capacity, so whether you have sufficient numbers of critical care beds and sufficient numbers of staff to run your service. The culture in your service in your hospital in terms of what kinds of patients you would admit for critical care support and which those that you would not admit for critical care support. And the resources that you have available to you. So what do you have in terms of actual physical space and staff, workforce staff, in terms of being able to provide care for patients. So we know that we need to do more in terms of looking at some of those factors and putting more finance into developing the service, and that is something that is going to be done. But again, it does require time to develop your critical care services, and there needs to be a speedier response. And an additional reason why we need to develop enhanced care services is really around the impact that it's having on services at present. So this is some data that is pre-pandemic data from Nazir Loans Group in Edinburgh, and they looked at the impact of readmission to critical care on mortality, and very clearly the fact that readmission to critical care has an increased risk of death and an increased length of hospital stay. And although there is a concern that in effect what's happening is that patients are being readmitted who were probably going to be readmitted anyway, underneath that all is a concern that actually this might reflect pressure on services and people that are discharging patients from critical care before they are ready to manage on the ward, and so are in fact deteriorating on the ward. And that is a real day-to-day concern. If you are managing a critical care bed and you have somebody who you feel may be ready to go to the ward in a day or so, and ideally you would like to keep them for another day on your service just to help get them a little bit fitter and a little bit better. If the implications of doing that are the fact that somebody may be having a cancer operation cancelled because they then do not have the critical care bed that your current patient is occupying, that impacts on the decision making. And there is a real fear at the moment that some patients are being discharged too early because of the pressure on the resource. In addition, the other impact that is happening in hospitals we see is the impact on our patient flows. So we know whatever system you use for defining your out-of-hours discharges from critical care, that there is an impact on patient survival and mortality. And this is work done by Peter Watkins' group in Oxford that's looked at healthcare systems across the world, over 2 million patients, and has shown that there has been a significant increase in patient mortality out of hours discharge. So there is a 40% risk of death if you are discharged out of hours, however you define out of hours, and a 30% chance of readmission. So again, when there is an impact on patient flow, as we are seeing with COVID at the moment in our hospitals, that means there is more chance of somebody being discharged out of hours from critical care looking for a ward bed. And clearly that has a significant degree of concern associated with it. So really, the development of enhanced care for surgical services is attractive to a lot of managers and hospital leaders who are trying to get their surgical services up and running again, because it provides a way of improving patient flow, helps you support some of your elective operating, and it can help address some of that increasing numbers of patients that have COVID-related deconditioning that we haven't been able to count before now because we didn't know about them in the pandemic or before the pandemic. But for patients, one of the real attractions, apart from the fact that you could develop a service that means that you're keeping separate your COVID patients or your patients that have infection from those that are coming in for elective surgery, is the impact that it might have on their quality of care. And patients that are involved in the enhanced care service development in the UK feel very strongly that this is something that could really improve the quality of patient care in terms of associated services like physiotherapy and mobilisation, some of the pharmacy services around medication reconciliation and ensuring that medications are prescribed and administered in a timely manner. So there is not just a sort of a quantitative benefit of developing an enhanced care service, but there is a real hope that we can develop a qualitative approach as well. One of the things that we are very clear in the UK is that this is not a service development for a deteriorating patient. So it's not a way of stepping down a patient from critical care who is not is at risk of significant deterioration, nor is it a way of providing a lesser form of critical care for somebody in a way of hoping that they will not deteriorate. It is conceived as a separate service altogether. One of the issues that we had in terms of the UK working parties looking at this as a service is how do you define your population? And to a certain extent, it's probably easier to say who shouldn't come to an enhanced care service than who should. So within the UK, we use the mortality figure, the 5% mortality figure of the National Emergency Laparotomy Audit, and say anybody who's got a projected mortality of 5% or greater probably doesn't need critical care. But somebody who's got a predicted mortality of between about 1% and 5% could benefit from an enhanced care service. Similarly, somebody who may need an enhanced degree of monitoring or interventions for a short prescribed period of time, perhaps for 12 to 24 hours around the perioperative period, might be benefiting from an enhanced care service and intervention. And everybody can probably identify some groups of patients who currently may be managed on a ward environment, but again, you can think, well, it would be perhaps a little bit better for them if they had some monitoring or a little bit more attention than they're able to get on the ward. And within the current situation of pressure on critical care beds, they are unlikely to get a critical care bed. So that might be somebody who perhaps needs some additional monitoring after some plastic surgery, or patient with obstructive sleep apnea who has a high stop-bang score. So really defining the population is very much down to your own hospital and your own environment and your own patient group. A lot of concern in the UK is around what you do around the staffing, the governance, and the size of your unit. And I'll talk a little bit more now about how that might look. The first thing to say is that in defining an ideal enhanced care facility, it's not really a way of saying your service must be this many beds, it must have this many staff. To a certain extent, your ideal service is the one that's going to work for you and your hospital, your case mix and your patient population. But within your service, there must be some defined elements. And those defined elements include clear ownership and leadership of the service, some developed policies and guidelines that staff can all adhere to, and that there's a clear process for data collection and analysis of patients' data to make sure that the right patients are going through the right service and receiving the right interventions. So as an example, when you're trying to identify which patients might come, we're suggesting you use some kind of risk assessment tool, some kind of review at the end of the operative procedure, but have clear links with your critical care service to make sure that you manage patient deterioration. And the idea of a workforce, because we're all under pressure with our workforce at the moment, is the concept of transdisciplinary working, which is not multidisciplinary working. It's working where you have a skills-focused approach and you say you will need some nursing skills, you'll need some medical skills, you'll need some kind of therapy skills for your patients, and trying to identify who in your workforce has some of those skills and how you can support them to develop them further to work in an enhanced care service. And again, that might mean that you will have staff working through a ward-based environment and an enhanced care service, or through a critical care service and supporting the development of an enhanced care service. And that has some attractions in terms of keeping up skills. I know the European Society has been extremely prominent in terms of its development of its COVID-19 skills preparation course. And this idea, I think, is very strongly held amongst many of us, that critical care skills shouldn't be confined to people working in critical care in the future. We need to have a wider distribution of skills amongst our healthcare workforce and make sure that we maintain those skills. So when we were doing some scoping of our enhanced care service developments, we were thinking that about 40% of people will need some additional training. And in the UK, we're focusing on skills passporting. That's that idea where people can say, I have these skills, and if you want me to work in this area, these are the lists of additional skills I would need to acquire. So this is the work that I need to focus on in terms of education and training. And the ESICM has obviously done a lot of work in this area already. So, for example, this shows how the approaches to care might work in terms of saying who's got medical decision-making skills, who's got nursing skills, and just identifying some groups of people who could work in those areas and be provided with some additional skills support. The other vital and important thing going forward is data collection. We don't yet have a clear method of financing this service, but it is something that is being worked on within the UK in terms of making sure that it is financed properly to recognise the fact that this is not ward level care, this is an enhanced level of care. And going with that needs to be some data collection. Many of you will know we have the Intensive Care National Audit and Research Centre that has focused very much on data collection for critical care, and its focus on data outcomes is mostly around mortality. But I think for an enhanced care service, we are very clear that we need to focus on some patient-related outcome and experience measures as well. So there's a lot of work to be done in terms of developing data collection for the future and making sure the data reflects the service that patients want and need, and also is accurately able to capture the cost of such a service. So in conclusion, what I would like to say is that the enhanced care development really is this idea of addressing the gap between unmet need and the wait that patients are having for their elective surgery. It's not a substitute for critical care resource, but it does need embedding in perioperative care pathways. And we view it very much as a long-term project that people can start working on now. Thank you.
Thank you, Danny, for summarizing and introducing all of us to the concept of enhanced care. It was very enlightening and inspirational. I'm sure there will be questions from the audience. Thanks for setting the scene. The aim really of this webinar is to introduce enhanced care, but also to highlight the importance of multidisciplinary, multi-professional working and engagement of families and patients. And with that in mind, I can't really think of anybody better than Professor Azoulay to talk about the how to enhance cooperation among caregivers and patients and families. As you all know, Professor Azoulay hardly needs any introduction. He is the president-elect of the ESICM with a wealth of experience in family and patient engagement. Eli, I hand over to you.
Thank you very much, Marlies. Good afternoon, everyone. I'm delighted to be part of the ESICM webinar, and I'm going to present you some data on how we can consider to create a healthy ICU environment. So I have no specific disclosure to report with regard to this presentation. So these are the people at stake in an ICU. We have, of course, the patient at the center, and we have the inside the ICU, the family members, the team, and outside the ICU, we have the consultants, and we have many people intervening. The multidisciplinary team, of course, includes only nurses and doctors, but also physiotherapists, directors, residents, nutritionists, pharmacists, etc. And every kind of conflict between people at stake in the ICU would have different consequences. Having a problem with the consultants would bring contradictions to family members. That is the bed of ICU conflicts. If we have an intra-family conflict, we are going to have an inertia in the decision-making process. If we have a problem inside the team, we are going to perform suboptimal decisions to create burnout, because we know that there is this interaction between ICU conflict and burnout, and we are going to hamper the quality of care. To enhance cooperation inside the ICU, one of the questions is whether we could improve communication. Communication is one of the major aspects that links people in a community like an intensive care unit. When we bring human interaction, when we live in the ICU, we can provide satisfaction, happiness, good work, satisfaction also for the family members, safety for the patients, patient satisfaction. We can reduce the burnout and as well as the moral distress. And there are many different studies that show that there is an association between how we interact and what we deliver, not only to patients and family members, but also to ourselves. And this is very important that now, for the 15 minutes that I have, we can share some very basic considerations on what we provide in the ICU. There are many papers, there are many studies, there are many qualitative interviews that lead to the obvious diagnosis that in the ICU, healthcare providers and every people at stake will experience symptoms as well as syndromes. For example, in Europe, 20% of the ICU beds are believed to be closed today because of the nurse shortage. And the nurse turnover is not only an endpoint or a clinical variable. It's something that impacts on how we are able to deliver the best critical care. As you know, an ICU bed is not a furniture. An ICU bed is an environment. Our people, the people we work with, the multidisciplinary team, are creating this environment. We also know that there are social issues that can interact in this ICU system, and we are going to see these one after the other. We know that these symptoms actually can maybe sometimes overlap, but can in turn report to patients, to healthcare providers, to family members, and maybe we could improve them by improving communication and by thinking on how we can improve the process of care. Everyone believes that everything is about communication, and it's true. There are communication gaps in the ICUs, as there are communication gaps in all the systems. And sometimes, even in the obvious, when you look at this from the outside, it can be very, very funny that people don't interact and work in parallel rather than working together. Still, people would not complain from the same things. It's about behaviors, it's about attitudes, it's about also the ICU climate. And we know that this climate refers to ethical climate, is, for example, when patients are hidden by many different machines, and we are bringing a critical care service that tries to improve the numbers, improve maybe the biology, but completely forgets the patient. We also know that if one patient is cared by one, or maybe sometimes two patients are cared by one nurse, doctors often have more patients and are those who don't spend so much time when patients are with difficult goals of care, when there's a decision to make. And sometimes it creates a kind of ICU conflicts based on what we can expect from ICU. So to conclude this part, we have different symptoms and we have different syndromes, the perception of inappropriate care, moral distress, ICU conflicts, post-traumatic stress disorder. But the source of all of that is the same: conflicts, communication gaps, suboptimal behaviors, difficult decision-making, family grief, physical strain, and the working hours. And the COVID-19 has only emphasized something that was clear before. And there are even studies showing that there's a lot of burnout, a lot of moral distress in healthcare providers, but in the same ranges of what we could observe before. And with patients and family members, we have, of course, an increase of frustration and PTSD because those family members were deprived from any ICU visit, but still we are higher, but we were in very high ranges of post-ICU burden. So we need now to understand, and us as ICU directors, ICU people trying to better understand and better lead a service, we need to make some differential diagnosis to be aware whether our ICU is an epidemic of burnout. So we need to have basic skills to understand what are the differences between depression, burnout, anxiety, moral distress, PTSD, because all of this would be in the ICU, but of course, all these targets don't have the same solutions and need to be considered differently. So the systemic approach needs always that we decipher every single situation to identify a target for improvement. It can relate to how we organize an ICU service, how we deal with emotions, and we will discuss this later, whether the vision is shared by the entire multidisciplinary team, and whether the ambitions at a patient level or at a service level are the same for everyone. So our commitment is to understand. We need to make the difference between stress and burnout. In stress, you can see that the person, the nurse, the doctor, they are here. But when there is a burnout, they are not there anymore, and no one would be there to complain. Stress is obviously an excess, whether burnout is really, there is not enough. When you're stressed, you have too much pressure, too much demand, too much physical and psychological stress. When you're with burnout, you feel empty, you're dried up, you're demotivated, you're hopeless. So we are in very different situation. Both of them, and burnout is the result of prolonged and chronic stress, but both of them have common symptoms, but it's very different, and we don't deal the same with stress and with burnout. PTSD also a definition, and we know that PTSD may affect everyone in the ICU, and nurses and doctors are not spared of that. Of course, family members and patients, this is part of the post-ICU syndrome. And the perception of inappropriate care is the way clinicians act in a manner that is contrary to their professional beliefs. So when you are in an ICU and you listen to people, you should maybe activate some keywords that are making the difference between these different syndromes. So burnout is really something that you can diagnose, and you can understand whether there's an epidemic of burnout by having a unit staff level and by giving voice to everyone to understand whether people would report on symptoms. But no one would go to the office of the ICU director, no nurse, no doctor, to complain from burnout, because we are not aware of it. It's a continuous process that takes people to a very stressful situation until burnout and an ICU a sick leave. So this is why we need to, when we have these unit staff level that are recommended to be performed at least one a week in every ICU, we need to be aware of that and to catch that. An ICU with a high level of burnout, a high level of moral distress or perception of inappropriate care is an ICU where there are conflicts and that cannot collaborate. There is no collaboration in such an ICU. Of course, we also know that PTSD happens in ICU nurses, and we know that the healthcare providers really complain about the systems, about how the ICU is organized, what we can deliver, but also sometimes it's related to conflicts with ICU directors, hospital administrators, and hospital directors. So we also need to understand that the perception of inappropriate care relates directly to the fact that we deliver a care to someone, and we just have the feeling that we are providing non-beneficial care. And this is really in a clash with our personal conceptions. So that makes a very different, that makes it very different from PTSD and from stress, but this is very close to moral distress. 27% of ICU healthcare providers report the perception of disproportionate care, and this is really associated with many different intentions, like, for example, the one to leave the ICU. Conflicts is something very personal, is something very that can be reported based on the feeling that we have had a difference in opinion or a difference in the way we were thinking we would manage a patient. In a study where a large number of ICUs across the globe were included, 70% of the healthcare providers experienced an ICU conflict over the last 7 days. And this was really associated with burnout, with job strain, and associated with this intention to leave the ICU. When you analyze a conflict, when you analyze a moral distress, when you have the feeling that there's a trouble and a problem between people in an ICU, you need to understand what's the source of it, whether it's about communication, about patient preferences and values, about the decisions, the coping strategies, expected outcomes, symptoms control, behaviors, leadership, or maybe sometimes just interpersonal animosity or mistrust. And you need to understand what's the source, because then you will be able to target and to make the ICU collaborate again. Another important thing is to understand whether this is something latent or if it's something current, or whether it is increasing and it's going to be even more violent, or whether it is improving, or maybe it's already behind. But everything that is already behind but has not been properly solved is going to react again and to create something at a patient and a family level, making that we would not be able to deliver the best of the critical care we can provide. So nurse burnout and patient satisfaction have been associated in many different studies. I like this study because it comes from a very nice nursing research showing that when we are in a situation of burnout, we are not able to care for patients and for family members. Again, there is an association between the stress and the strain that we put on nurses and their intention to leave the ICU, but also on patients' outcomes. And this has been reported recently. When we add strain and stress to the nurses, we have an increase in ICU-acquired events and in patients' mortality. I would go now to a more important thing that has been reported is that working together, and there are two things that have been reported. One is nurse participation to daily rounds, and I don't think that we should consider that the daily rounds are medical rounds. We should consider that there are nurse and doctor rounds, and it has been associated with less ICU conflict when they are doing rounds together, less perception of inappropriate care because we can interact, less ICU-acquired events like self-extubation, improved satisfaction at a patient, family, and healthcare provider level, and reduced burnout. And after all, I just believe that this is the normal way we should care for patients by having common rounds. Another thing is when nurses and doctors are able to inform together the relatives, it has to be daily for short and long-term conversations, for important or for small things, and it is associated with less contradiction to family members, more family satisfaction, and less symptoms of anxiety and depression for family members. One of the way we can improve the way we collaborate and we work in an ICU is to avoid having visiting policies that are too restricted. I can consider and understand that for some ICUs, we need to have some hours without the family members. But many ICUs are open 24/7 and are really inviting family members to be there as much as they want. Because when family members look at you, a nurse or a doctor caring for the patient, they see a healthcare provider. If you are restricting and having the family members only when you are not in the room, so you are not a healthcare provider. You're just a bystander. You're just someone there, and they don't know who you are unless or until you are providing a bad news. Of course, extending visiting hours for family members does not imply that we are informing family members all the time. So what we do is that we have happy hours for family members, times, dedicated times where there's a family around, like for example, early in the afternoon or after the ICU round, or when family members are more available after work or when it's better. But we should be able to provide information to family members 24/7, if it's possible, because some family members need to continue having a normal life to care for their kids and come to the ICU to visit and be involved in the care of the patient. Another view of that is that some consider that we should control our emotions instead of putting our emotions and having an ICU behavior that is based on our emotions, like, for example, moral distress or perception of inappropriate care. But I don't share this view. I really believe that we need to understand emotions and to consider whether it can be harmful at a patient, a family, or a healthcare provider level. What we need to avoid is not paying attention to alarms, not seeing that the healthcare providers are in resistance until they fell and they are in a situation of exhaustion, and then it's too late, unfortunately. So I would consider that we need to manage emotion at work, and we need to have a self-awareness of these emotions. We need to regulate them. We need to bring from them motivation at an entire team level. We need to use these emotions to provide empathy. And we need also to have social skills that make life in the ICU much easier. That being said, we need to accept that everyone at any level has to improve the leadership, his or her leadership, by starting with ourselves. I think that we need to improve our self-awareness and self-regulation by increasing empathy and social skills. We need to be actors of the improvement of the the working climate. And I think that we need to focus on everything, what can be heard and what can be understood, even if no word has been really voiced, and we need to consider that. So perception of inappropriate care really is the result between an imbalance between communication and collaboration. And this is exactly the same for the intention to leave the ICU. It's an imbalance between how we discuss and what we decide. So everything is related, and you can see that the number of healthcare providers having the intention to leave the ICU, and these data are from Dominique Benoit and have been published in the Disproportionate study, is really an imbalance between what we make, the decisions we make, and how we discuss these decisions. So for every decision, we need to consider that there's a compromise to make that spares everyone. And sometimes it can be a win-win situation, but sometimes we need to make a decision and to go on making a decision for the patients with the family members, and in an ICU to create a safer ICU environment is very important. 1 or 2 minutes, maybe 1 minute to just mention that everything is a subject of debate. We need to discuss everything, even when it's obvious. So we cannot use the authority of being head of the department to impose something, because then we create frustration. We need to have this kind of ethics of discussion, making that everything will be self-appropriated by everyone and will be the result of something that is no more fictive, but this is the reality and the result of communication. Even when it's very obvious, if you want to change the visiting hours in your ICU, you should go from the start and really create a basic environment and improve everything by the means of communicating better. This is true for brain death. When we involve family members to understand brain death, we are able to examine the patients with them and to improve the understanding of brain death. This is true when family members are witnessing CPR. We know that they are much better even 1 year after the cardiac arrest. And this is true when we are opening ICUs 24/7. We know that we are not reducing delirium, that was the intent of this Brazilian study, but we are really reducing family anxiety and depression. So to conclude, in our ICUs, everything is fine. But the mistake stands in the belief that we are fine. We need to really address everything. Pay attention to yourself, be happy, learn and teach to everyone in the ICU, change your opinions and induce changes at the same level, collaborate, communicate, make decisions even when it's difficult, and the patient is always your priority. Thank you very much.
Thank you, Eli. And again, thank you, Danny, both for very inspiring talks. We've already got some questions from the audience. And the first one, I think, is really for both, but maybe, Danny, for you to start. So you described the principles and the importance of enhanced care. And one of the people listening to the webinar is asking, how does this distinguish from intermediate care or step-down care?
Yeah, I think that's difficult. I think one of the things that the pandemic has shown, certainly in the UK, is the difficulty we have in terms of our hospitals infrastructure. We have a lot of old buildings and a lot of wards that are not designed for patients that have infective diseases. So the concept of enhanced care is around a completely separate pathway. So it's not a step down from a critical care facility or a step down from an acute facility. It's the idea of a service in which you keep your elective planned patients who are COVID-free or infection-free completely separate from what else is happening in your hospital. So some units do have step-down facilities, but this is not envisaged in that way as a step down from a critical care unit.
Great, thank you. There are some compliments coming into the chat box, which is great. So thank you for these great talks and lectures. We have another question, and it's, I think, for both. And it relates to post-ICU follow-up care and follow-up monitoring. Is it necessary, and should it be done by somebody from the intensive care team? What do you think?
Shall I defer to Ellie to start with?
Okay. Ellie, do you think it's useful beneficial to have post-ICU clinics? And if you do think they're useful, should they be done and be held by intensive care clinicians?
Yeah, I really believe that there's an understanding of the post-ICU management, not only by not only for the patients, but also for family members, and this is what we do. So we consider that what we need to do is to screen for the post-ICU syndrome, the PICS, for patients and for family members. And we are ourselves ICU healthcare providers able to understand and sometimes to direct patients and family members to the appropriate management. So there are many ICUs doing that to provide a kind of rehab, but also to screen the physical, the mental, and sometimes the emotional and social symptoms that complicate, that might be part of the post-ICU burden. So I would say, yes, it is very important. It is our commitment. It is also another job for our people. And I think that this is very good for people to have different kind of roles in an ICU. So I'm very much in favor of that, and I'm very happy with the results of that.
Ile, could I ask a follow-up question? Do you believe, I mean, you pointed out the fact that sometimes doctors and nurses may find it difficult to care for patients. They may find it difficult to provide care which is in their eyes is inappropriate. They may struggle with certain situations. Do you believe a follow-up clinic helps seeing the patients afterwards?
So this is a very good point. There are two things and two different levels. One is what is difficult is to provide and to deliver a service, a care that has not been discussed and has not been properly shared inside the team and with the family members. When this care, when this service has been the wish and the preference from a patient and a family view and has been discussed within the team, I think it makes it much easier to accept. So there is a balance between how we decide and how we discuss. The other part of your question is very, very relevant because having a nurse looking, for example, in a situation where it was very difficult to decide whether we should provide dialysis or whether we should prolong a time-limited trial, and then we see how it translates into physical and mental outcomes, this can really change the perception at a person level, and maybe people will think differently for the next patients. So I'm really convinced of that.
Danny, would you like to add anything?
I would support what Ellie was saying and just also maybe make the additional comment that we know our populations are getting older. And as people get older and they come to critical care, those outcome measures are not just simply in terms of mortality, particularly for older people. The idea of independent living, the impact it has on their lifestyle, will impact significantly on some of their decision-making around major surgery and admissions to critical care. So without having those kinds of outcome measures and that kind of data to be able to say to older, frailer people, this is going to be the likely impact on your life, to a certain extent, just quoting mortality alone isn't particularly helpful.
I really agree with
that. We have more questions coming in. And so, Danny, you talked about enhanced care. And Eli talked about opening the doors and ICU without walls, including our colleagues. So the question is, would you say that enhanced care and ICU without walls are similar concepts? Eli, do you want to start?
Yeah, well, not at all. I think that not only we need to have walls, because this is much reassuring, and we need to have an identity inside the hospital. This is good for patients and family members. This is good for the healthcare providers. So I would keep walls. However, I would not put their authority, I would not misuse my decisional capability to make that it's a barrier. We are not going to create a barrier between the patients and the family members, or between the team and the patient and the family. And the COVID-19 has been a very good demonstration of that. At many places, we did not implement the restrictions that were recommended, and we had family members in the ICUs, where in other places it was very frustrating. So I would keep walls, but I would manage them so then they are easy to pass through. However, there's a concept that should be adapted. We are there to restore relationship between patients and family members, and to normalize relationship between the team and the patient and the family members. I think we should just accept that we are not able to appropriately care for a patient when there is no family member, and we should accept that we are not able to work only with nurses or with doctors. We are a multidisciplinary team. We are not able to have the same outcomes if we are only on our own. So this is why we need to be together. I would break the wall, but I would keep the wall.
And Danny, what do you think? Are they separate concepts, enhanced care and ICU without walls, or do they try to achieve the same aim?
For me, I think the underlying thing, and maybe the message I've taken from Ellie's talk, is really it's about bridge building. It's about recognizing that there is expertise in one area and that a patient's care is a spectrum of care, and it doesn't finish at one point and immediately be taken over at that point by another group. So in effect, we do need to start building bridges both as a team, our skills and making sure our skills are supporting the people who work on the wards and who work with us. And as Ellie was saying, this idea of having people being involved in the care of somebody on a critical care unit and recognising that they have something to contribute as well. So I see it as a bridge building concept.
Thank you. Danny, we have a question here, I think, which is really for you. The person is saying that monitoring in the wards can be quite challenging in some parts of the country, some parts in the world, for many reasons, including staffing reasons. In your opinion, what is the biggest challenge to implement enhanced care?
I think the biggest challenge in healthcare at the moment that we all have all around the world is workforce. We have not got enough people to work in our healthcare systems, and then we need to train them to have a skill set to work perhaps more widely than we might have historically done. So I think one of the issues around the ward is not just the provision of monitoring, it's about having sufficient people with a sufficient skill set to recognise what that monitoring is showing, really, would be my take on this.
Yeah, thank you. Elisa, anything you want to add? I mean, we've talked before about the major nursing staffing crisis in many countries at the moment following COVID.
Well, it didn't start with COVID. I think it's a process where people were already exhausted by many different healthcare policies, and I know it's different from one country to the other, but you know, basically the feeling was almost the same. One thing is that we have reached a situation where we consider that healthcare providers and our nurses, our residents, fellows, and attendings are precious. And I think it's time to just voice that. I think that when we say, well, 20% of the patients with RDS are dying, 80% can survive, this is the result of a huge effort made by the team and this team has to be considered that we have standards across Europe and across the world. And these standards need to be considered also as the basic standards, because this is the only way we can report the outcomes that are expected by the world, by patients, by family members, and by the lay public. So I think that we should communicate more. And this is how having patients and family members guiding the way we are using the language, the way we are conducting research, and the way we are teaching to others is very important. And I think that this move and the ESICM has been much involved in that. And at the opening ceremony this year at Lives, we had these patients and family members witnessing what they underwent and how it was for them. I think that we learn a lot, and we need now to learn in turn how we can communicate to them and to the lay public. I think it's time for that. We reach this time.
Thank you, Eli. So Eli, you elegantly outlined the high risk of conflict, the high risk of burnout amongst our colleagues. And you said that we have to look after each other and care for each other. So there's a question here: in a conflict or in a burnout situation, who do you recommend to consult for help or mediation?
Well, this is another very good point. So I believe that we are a chain of people, and this chain is responsible for each other. So we should start by ourselves, but we should pay attention to everyone. So then when something happens, the question is whether the solution is internal or is based on another person's intervention. Well, there are the two options in the real life experience, in the literature, as well as in the professional environment outside the hospitals. One thing is sure, the worst situation is when we do nothing. The second thing is there are different climates, making that some people would accept better that observations and comments come from another team, and some would accept that it comes from someone outside the hospital. So I would really act according to where you are, what's the ambience, how is the hospital, and whether there were tensions much before that. The third point is that we are all able to find a solution, and if we are able ourselves to act on something and to accept that we have a problem that we need to improve, so then we have more chance that it translates into reduced burnout and improved a better ICU climate. So I would say that as far as we are able to identify someone to either observe and report or intervene, we are good. The worst situation is when we refuse the dialogue, when we refuse interactions, when we are not able to sit down and consider everyone's position and opinion. So then I think that there's something much difficult to do.
I think you both are touching on very sensitive nerves at the moment, because there are many questions coming in at the moment, all related to stress, risk of burnout, and the real challenges at the bedside. So I just combine two questions now, simply because we're running out of time. But it is that people are asking, this is a real situation. We have a staffing crisis. We are at high risk of burnout, doctors, nurses. Are there any real immediate solutions? And then I'll put it to you, are there any alternative therapies? What can we do immediately to tackle these real life-threatening issues?
Well, there are solutions. These solutions can be either simple or a little bit complex. So first is to get an awareness of the situation. I think that sitting together, showing that we share the same experience and we are undergoing the same work and professional experience is very healing for the entire team, instead of having the feeling that you are lonely with your own feelings. So this is one point. The second point is create an ICU environment. Just to give you an example, well, sometimes people are stressed and there's a problem that is disconnected from the burnout or from the strain that is on people's shoulders. But you could just make life easier for another thing. Like, for example, you could make the handover earlier for people getting earlier at home. You could maybe consider that it's time to adapt the way you work together. You could maybe consider that the number of patients per nurses could be organized. You could consider that people could round in the department, being in the step-down unit and in the ICU from time to time. But I'm not sure that the result is the most important thing. The important thing is that you have a movement that shows that you are not only aware of the situation, concerned by it, and making every effort. Then there are many different things that have been tested for example, to have nurses and doctors doing a 5-minute nap in the afternoon, or to have people improving their interactions by having a lunch together or by having different things. Mindfulness has been tested, improving communication has been tested. I think that for now, I wouldn't say that there are miracles that can be performed. unless we are just we are aware of the situation, we're making effort, and we maybe change things according to the common feeling.
Thank you, Ili. I mean, at the end of the day, everybody comes to work, and everybody who wants to do a good job. That's what people come to work for, and it is currently quite challenging. Danny, do you have any other advice how to tackle with the immediate problems as we face them every day?
Yeah, I mean, as Ellie has said, I think the important thing is that you are actually listening, engaging from the ground, from the workforce, what the day-to-day issues are. And also recognizing who has significant mental health issues, because they need a separate degree of support from those who need other attention to factors that impact on their day-to-day living. I think one of the things that's come through very strongly, and I think particularly in London as well, in terms of the resetting after COVID, is people have a strong desire to have education and training, and finding a way that you can provide that education and training, particularly maybe even paying staff to come in for their training sessions on their days off, but finding a way to restore some of those other aspects that go with professional support, respect, pride. Those are the things that are actually being shown that people want. So without actually asking what people need and finding ways to provide it, it can be very difficult if you just assume that everybody has got a psychological problem, because that's not the case.
Thank you both. We have come to the end of this webinar. We've actually already overrun a bit. And I still have more questions here, which I could ask. Clearly, there is a lot of interest, and you have touched on important topics which affect our colleagues at the moment. I think you both highlighted the fact that we all have a role here. We all can look after each other, whether we are a nurse at the bedside, a doctor in training, or the director of the intensive care unit. Ultimately, we can all hopefully make somebody's life a bit better, our colleagues' life. There's clearly more to do. Together, hopefully, we will get through this difficult wave. Thank you for sharing your thoughts and your insight. I have learned something new. I've had new ideas, and I hope that the audience listening to this webinar can go away with new ideas and new inspiration. I'd like to thank you for your time. I'd like to thank the audience for putting a lot of questions in the chat. And I'd like to thank the ESICM for putting this important webinar on, supported by GE Healthcare. Have a nice evening.
Thank you. Bye-bye.
Thank you.